Good evening, everyone. My name is Ben, and I'm a health educator here at the Hospital Research Foundation Group Arthritis, and I welcome everyone along tonight to another one of our webinars. I'd firstly like to start with an acknowledgement of country, and that both myself and the presenter present from Ghana land tonight, and we pay our respects to elders past, present, and emerging. Now, tonight's webinar is Arthritis and Podiatrists, More Than Just Feet, with Adjunct Associate Professor Angela Evans. Angela is a professor at La Trobe University and a practicing podiatrist in Adelaide. She is well renowned for her contributions to podiatry and global health initiatives and has authored numerous journal publications, book chapters, and Cochrane Library systematic reviews. Her research lists over 140 publications with 200 lectures globally. Alongside her clinical and academic roles, Angela has volunteered for medical teams at the prestigious events such as the Sydney Olympics, Melbourne Commonwealth Games, and the Special Olympics in Nanago and Adelaide. Since 2008, Angela has served as a volunteer research coordinator and ambassador for Walk for Life, a sustainable clubfoot project in Bangladesh. Her contributions were recognised in 2019 when she was appointed a member of the Order of Australia for significant service to community health in the field of paediatric podiatry and to professional standards. In addition to her professional achievements, Angela has had roles in healthcare governance and advocacy. She holds many roles across the Australian Podiatry Association, including being vice president. She's also served as an assessor for the Australian Health Practitioner Regulation Agency, or AHPRA, to ensure high standards of podiatry in Australia. We're very lucky to have Angela along, and it's harder to get a podiatrist kind of more qualified than Angela. So thank you very much for spending some time with us tonight, Angela, and I'll hand over to you.
Thank you very much, Ben. That's an extremely generous introduction, and good evening to everyone who's online. And I'd just like to echo Ben's acknowledgement of country. I too acknowledge that here we are on Ghana lands and pay my deep and enduring respects to all First Nations people. So it's quite a big topic, the foot and ankle arthritis. And of course, it could be weeks and weeks, but fortunately, we're here for just about an hour. And I will be trying to address this through the lens of podiatry, feet, foot conditions, and community health. But this is the advantage of having question and answer at the end. So the outline that I've been given for tonight is to try and cover, amongst other things, what podiatrists do and what our scope is, our role in helping people with arthritis, and how podiatrists can help people with any joints from the waist down, clearly through an arthritis lens, and also just practically how you can see one, and many of you, I'm sure, already do. A little bit of context. As you probably know, arthritis is really quite common in Australia and everywhere. In Australia, the estimates are 1 in 7 Australians have some form of arthritis, which is over 3.5 million people, all walks of life, all ages, children, older adults, younger adults. There are huge health costs associated with this. And hip and knee replacements alone, very common joint replacement procedures, are projected to be over $5 billion in just 5 years' time. We know that part of dealing with this is to try and diagnose all forms of arthritis earlier so that we can manage them better and that they can have less health consequences for the individual primarily, but also for the healthcare system that we all depend on. And part of this too, we want more access to preventative care, and that often needs to be multidisciplinary, particularly around keeping people moving and keeping them strong. And high quality research alongside that can make us more effective in clinical management of people, which makes us more effective as a community with our healthcare system. So the two are always interrelated. Bit of background and terminology, I guess. Arthritis, What we really mean is rheumatological diseases, and there's a range of them, as you probably know. The word arthritis is, if we look at it, is arthro really refers to joint, and itis means inflammation. So in bare terms, arthritis is joint inflammation. But we do know that rheumatological diseases span more than just joints. Osteoarthritis and rheumatoid arthritis are probably the two most common variants, but there are also arthropathies, joint pathologies, joint diseases that affect the joints of the spine, crystal arthropathies, the really well-known one is gout, connective tissue diseases, things like scleroderma, skin diseases like psoriasis, and in children, juvenile idiopathic arthritis. And some of these conditions can overlap. If we look at the joint as it's affected by osteoarthritis in this picture, we can see that the joint itself is affected. We can see that roughening of the articular cartilage and the closing of the joint space. And whilst there is a thickened inflamed synovium or joint lining, it's nowhere near the same as it is in rheumatoid arthritis, where the joint space is actually preserved, but the inflamed synovium spreads right into the joint, and it's very inflamed and sore and pinched. I'm using as sort of accessible, the most accessible terms I can. And most of you who have these experiences will relate to that and use your own language. What's important with all of these arthritis or rheumatological diseases is that foot and ankle problems are really common, and foot and ankle pain is in fact the most usual complaint, and it's often one of the complaints that is there even at or before diagnosis of arthritis, and clearly that makes day-to-day life difficult. So having set some general terms and trends, we know that arthritis experience varies from person to person, and even with the same particular subtypes of arthritis. One thing we also know, and this is going to be what my main emphasis, is that the benefit of exercise is absolutely universal for nearly everyone with nearly every type of arthritis. And if I can just get this little video going, it's a video that comes from the UK arthritis group called Versus Arthritis, and I think it's really good. Just have a look at this.
Within my role, I see a lot of people coming to me that with osteoarthritis, particularly knee and hip arthritis. So this Versus Arthritis group is great to get them involved, to continue on their rehab. Their physio is only the beginning of their rehab. It's a low impact sport. It's helped there to build endurance and muscle strength.
If you've got pain, the last thing you think you want to do is exercise, but that's helped. It really does help.
If you can walk, stop a ball and pass, then you can get involved. But if you're exercising, you start to feel good, you're getting out, you're meeting other people. You start thinking about healthy options, you start looking at your food, your drink.
And when I came here, if I dropped something on the floor, I couldn't pick it up off the floor. I was stiff. I was sat behind the desk for 5 years. And coming here, gradually, my speed has built up. It hasn't cured up, but makes it so much easier.
Everybody's arthritis is specific to them, so they will have different symptoms and different techniques to manage their symptoms. So if they can share those with each other, then great, helping each other out.
The walking football, I think, has helped to strengthen my back and bones, and hopefully, I'm not going to go back to where I was.
I can get out in the garden, I ride my motorcycle now. It's just given me a complete change of life, total lifestyle change.
Okay, so I hope you've found that useful. I think it's a good little clip of showing how people with arthritis and pain can understandably be pretty reluctant to exercise initially. And yet, if they can gradually, at their own pace, bearing in mind it's different for everyone, there are so many benefits. And if people are feeling better, that aspect of mental health is very important for pain management and, of course, getting out and being involved with other people, that social side of feeling better. So I think, as I said, whilst arthritis really varies, the benefits of exercise is universal. And of course, it's fundamental as far as podiatry is concerned, because most forms of exercise involve, walking or running and involve feet. What we often do as podiatrists is that, particularly in older people with arthritis, I tend to often say to people that, we need to kind of think of spreading loads so that not all of your exercise is only weight bearing on feet, but it might be what we call semi-weight bearing, things like cycling, swimming, rowing, where you're still getting exercise, but in the case of, say, cycling and even rowing to an extent, you've got resistance through your feet without full body load, and particularly without impact forces, which you get more from walking and particularly running. But there are so many different forms of exercise, and the most important message is just to move and keep moving. But different forms of moving can really help inflamed joints, because if we can move the loads from one area to another area, the area that's been loaded rests and settles down, while the next area that hasn't been loaded can actually take that load, become a little inflamed, but then rest when you do another exercise. So this notion of spreading loads is actually really important and can keep people moving, which keeps them strong, and strength is crucial. Why do adults over 60 need strength training? Well, it's all about preserving your strength through muscle size. It's very important through the tension of muscle traction across bones that helps bone density, and through preserving bone density and muscle size and strength, we can prevent loss of mobility, which is also associated with loss of independence. The big fear, of course, is falling, and anything we can do to lower the risk of falling and the injuries that can come from that, we need to grasp. We know that strength training and reducing falling risk go hand in hand. From a metabolic point of view, we know that if people can do strength training and keep their muscle size as large as it can be for age, it also improves insulin sensitivity, which helps to ward off conditions like type 2 diabetes. And again, along with a sensible diet and adequate exercise, which is where functional feet come in. So staying mobile, staying fit and functional, it's all about getting you to enjoy the things that you do, retain your independence, retain your health. Very much like that soccer video that we just watched, getting out there and starting gradually and then building up slowly so that you actually maintain or even improve strength rather than lose that, and maintain quality of life. So podiatrists, what do podiatrists do? Well, we diagnose and manage problems with disorders, injuries, and pain affecting primarily the feet, but also very much associated the next door joints of ankles, knees, and legs. Some podiatrists also prescribe medicine as endorsed prescribers, particularly some anti-inflammatories and analgesics or pain relief. So podiatrists are about supporting health by supporting foot health, and very much about supporting mobility and independence. And that's all about strength and balance, warding off falls, keeping people active and maintaining quality of life for as long as physically possible. And we know that moving and strength are the two critical things that make a difference to people's quality of life at all ages, particularly as people get older, and particularly if people have conditions like one of the arthritis family. Keeping moving maintains strength and offsets some of the pain. Where you'd find podiatrists? Well, a lot of podiatrists in Australia are in private practice. They're also in community health centres, and some are in hospitals. They can be in cities, suburbs, rural, and some remote regions as well. Some podiatrists do online telehealth consultations, which can be very good, particularly for the initial interview and consultation, and sometimes for the review checkups as well, which saves a lot of travel. You'll also find podiatrists in rehabilitation centres and in residential aged care, where again, it's about, sure, routine foot care, but footwear and trying to keep people moving so they're strong enough and reduce falling. We also work in some parts of the disability sector, and some podiatrists do mobile work in people's homes. So there's a variety of settings, as you can see. And we'll talk at the end about how you can actually locate one depending upon where you are. So the main points I'm going to be trying to get across to you tonight are the importance of exercise, and I think we've probably established that. Another thing that's really important as far as feet are concerned, and a concern for podiatrists, is people's body weight, because we know that when people are carrying too much weight, that's not good for foot pain and it's not good for health. And then the other thing, as part of both of these we'll talk about, is footwear. So exercise, body weight, and footwear are the three things we'll address. It's worth looking at some of the recent research. This is from 2023, that across the community, foot pain increases as people get older, so that 1 in 3 middle-aged to older adults have foot symptoms, which are defined as pain or stiffness or aching on most days. So that's 1 in 3. That's independent of conditions like arthritis. But those who are more likely are females, those who identify as Black, those who are obese or overweight, those who are older, or those who are on their feet doing routine manual occupations. And the figure seems to be where 5 or more hours on your feet a day sees people more represented as having foot pain. Foot pain and symptoms are associated with less physical function and more disability, particularly as time goes by. And that affects independence and participation in work and social activity and anything that involves physical movement. Foot symptoms due to osteoarthritis have actually been associated with a shorter lifespan, and it's probably because people move less, become weaker, and then are more likely to fall. So this association between moving less and getting weak and falling, we need to be very well aware of, which is why exercise is so important and always something that a podiatrist is looking at. Exercise, if someone has been very inactive, we need to get people exercising gradually, and then maintain that as their strength improves. Body weight, if someone's body weight is really high, then that's something that we can't change quickly, but it needs to be addressed as well, but clearly takes longer. Footwear, on the other hand, is something that we can address quite quickly, and sometimes that alone can have significant effects to someone's pain, comfort, movement, quality of life. But feet are complex, right? And I guess as these pictures show, it's all very well to say, well, get exercising and reduce some body weight and get comfortable footwear that keep you active. But the foot is a complicated thing. There are 26 bones just in the feet. And then you can see here the way the foot connects to the ankle. So this is the outside of the ankle, the little toe side, and the inside of the ankle, the big toe side. This is a really crucial joint, and this bone here, called the talus, is quite interesting in that it doesn't have any muscular attachments, so it can interact with these joint surfaces of the ankle, but also these joint surfaces of the foot, which is essential for giving the foot a lot of movement to make it adapt to uneven surfaces. You can also see that there are a number of ligaments and tendons in the foot, which should be operating, particularly the tendons, in equal and opposite pairs, flexors and extensors, to keep all of these joints stable when they should be stable, so that the foot can deal with body weight and movement and different loads. So that's a very simple overview of a complex part of the body. What I'm now going to look at, again through this lens of exercise, body weight and footwear, is I've just picked out 5 conditions that are common in feet and arthritis. And we'll go through these relatively quickly, and you may have some questions about some of them at the end. I will focus on this big toe joint, which might seem strange, but I think that will become clear. But you can basically see that starting off with the Achilles tendon, and there are 2 things we like to sort out as podiatrists when people come in with Achilles tendon pain, and that is whether the pain is where the Achilles tendon joins the bone of the heel, what we call insertional Achilles problem, or whether it's higher up, higher in the mid portion of the tendon itself, so not involved with the attachment, but actually within the body of the tendon. If we see Achilles, people with Achilles tendinitis, we really, as podiatrists, are one of our differentials, or one of the wider factors we consider. Is it purely an Achilles injury, or is it associated with a type of arthritis, and particularly rheumatoid arthritis, which I've abbreviated as RA, or psoriatic arthritis? They're the 2 that can present with Achilles problems, particularly insertional. Wider than that in our history, the story that the person comes in with, we are more suspicious if someone has chronic low back pain, particularly if they're younger than 45 years of age, because that may indicate what's called a spondyloarthritis, or arthritis in the spine joints. And we're also looking at not only the skin, but the extension of the skin, the nails, to see if there's any evidence of psoriasis. So if there's chronic low back pain and it's been a problem before someone was 45, their nails look a bit pitted, or their skin has evidence of psoriasis, or the person knows they have psoriasis, could be under their armpits or in their head, not always visible, then one of the things we would think of is this actually an inflammatory condition, that not just localized to the Achilles. And we work with very closely with GPs to this end, and looking at appropriate blood tests and things. If we're looking now, I'm just taking you straight into the big toe joint, because this is, and would you believe, there are actually conferences just about this particular joint. So in osteoarthritis, you can see here, these 2 bones are both compromised, the big toe, 2nd, 3rd, 4th, and 5th. This joint here, where the big toe joins the foot, we can see here on the x-ray, you can see that that joint has little spurs called osteophytes on the end. That just shows wear and tear. And you can also see that the joint space is very narrow, and this whitening we call sclerosis, which shows there's a degenerative process of the articular cartilage. If you look at these other joints, see how they look nice and clean and there's good joint space? This is the one that is affected with osteoarthritis. If we were to move that, we would find that there was very little movement in that toe. And of course, we always test the other side for a comparison. The arthritis can also affect this joint, but in this x-ray, you can see that looks quite clear, although there are some little bony spurs on the side. Rheumatoid arthritis, by comparison, is usually more inflamed and swollen. The movement of the joint might be all right, although painful. So that's one of the delineators of those two. Why do we focus on the big toe joint? Well, it's because of the way we move. And I'm just going to try and show you how important this is, because this one joint in the big toe interrelates to the ankle and the knee, the hip and the back above. Because if you think of the way we walk, this is the hip, by the way, this is the knee, ankle, foot, heel, toes. When the foot hits the ground on the heel, the leg then comes forward over the ankle. And in doing this, the knee and hip come forward as well. So the whole body load is starting to come forward over this ankle, and the toes come down to the ground. So you can see this movement. The toes come down to the ground. The leg comes forward over the ankle. So we need to have an ankle that moves really well. If the big toe has a problem, which it often does in arthritis, when the next stage of the step, when the heel leaves the ground, the body weight comes forward to the front of the foot. As the lower leg comes forward further, the knee begins to bend and the body weight comes forward as well. If that joint doesn't move as the heel leads the ground, that creates a lot of pain, and the person has a few options. They can either bend their knee more to try and get over that stiff joint, or they can lift their whole foot off the ground, which again involves bending the knee. And it often means that they have to bend their hip a little prematurely too. So they take shorter, stiffer steps. And this is often unstable in an older person. So if we look at it again, we can see that normally when the foot hits the ground here and then rises up, the joint should bend really well. And this joint moves in opposite directions because it's free to glide. When what we call the joint is limited, then we can see that the ability of the foot to rise is reduced, so that the type of walking pattern has to reduce. That just won't bend any further. So they have to lift their whole leg, bending knee and hip. And that can make some people unstable, particularly if it's more on one side than the other. If it's rigid, it doesn't bend at all, then really, once the foot hits the ground, the person has to walk quite differently, or they experience a lot of pain due to that joint being so stiff. So I hope that just shows that this one big toe joint, if it's not working properly, can have significant ramifications right through the foot and lower limb, and very much to someone's gait pattern and their stability. So I'm going to move on now to talk more about this one very important foot joint and some of the many conditions that affect it. And the reason I'm emphasising this is because this is really common for people with foot pain and arthritis. and it's a cause of great concern often. So we're still on the big toe joint. With osteoarthritis, one of the things we often see is hallux valgus, as we call it, with the bunion. So hallux valgus just means the big toe, or the hallux, is moving away from a straight position versus this big toe joint. And we can see the mild, the moderate, the larger, and the severe bunion deformity. See too that relative shortening of the toe when that deformity is advanced. And you can imagine, apart from anything else, that is really difficult to get into a shoe comfortably, and it can be very uncomfortable to walk on too. Sometimes with osteoarthritis, when the joint is rigid, because these are not always rigid, they're often just awkward and uncomfortable due to this deformity. But sometimes with osteoarthritis, we can get a stiffening joint on the top here, which becomes very painful and again rubs on a shoe, and this joint doesn't bend. You can see that more here. And you can probably also see that the big toe has bowed in the middle to try and get some movement. This can also happen back in the middle of the foot where my pointer is, but this particular joint is very common, and the bunion, I'm sure many of you have either had or heard about. With rheumatoid arthritis, the principal effects for the big toe joint is from the autoimmune effects of this inflammatory arthritis, because it has a real liking for the small joints of hands, but also feet, as well as ankles and knees and elbows. In fact, 90% of rheumatoid arthritis, people develop arthritis in the feet and ankles, and 20% of people have symptoms, generally pain, sometimes swelling in their feet and ankles at diagnosis. We can often see too, we get a thinning out of the fat pads under the feet, and these feet become not only misshapen, but very painful for weight bearing. And again, podiatrists can help with that, with footwear and with cushioning orthotics. If we move on now to just talking about psoriatic arthritis, which is, yes, inflammatory, but also autoimmune. And we know that most rheumatological diseases are a mix of the two. And psoriatic arthritis, as we've already mentioned, affects skin and joints, creating stiffness and swelling. Over here, and in children, this is probably one of the more common signs, again with alongside ankle swelling, is to see one toe swollen in isolation. And certainly if I see that in a child or a teenager, I'm very carefully going through a history of other joint pain, particularly low back pain, and the family history of rheumatological disease, and sending them back to their GP to get a full blood picture, because we know that if we diagnose arthritis in children and young people, and anyone really, earlier, then we can get disease-modifying medication, which means the joints are preserved, and these people do better over time in terms of their physical functioning. But that little sausage digit is a bit of a giveaway. Heel pain is also common with psoriatic arthritis. Sometimes people won't connect the two. They will know they have psoriasis, and then they think, oh yeah, I've got heel pain, which is a common condition in the community. 1 in 8 to 10 people over the age of 45 have heel pain independently of any form of arthritis. So it's not surprising that people don't always put them together, but psoriasis and psoriatic arthritis overlap in about 15% of cases, and heel pain can actually be part of that, with inflammation of the foot fascia, which is sort of like this, the thick skin under the skin, if you like, that spans the arch. The Achilles tendon, again, can be inflamed or can also have a level of degeneration, and again, pain near the heel, which might be, as we've said earlier, insertional or mid-portion. And then the nails, the appendages of the skin, can be thickened. They can have these funny pits or striations, or the skin itself can have frank psoriasis, and it may be in the feet and other parts of the body. So still on the big toe joint now, all these different types of arthritis affect the big toe joint differently. Gout, and if anyone's had gout, you'll be wincing about now. Gout is due to increased uric acid, which manifests as crystals within the joint, and intense sudden pain, swelling, redness, and a great liking for this big toe joint. That's really one of the most common joints affected. Also, some swelling around the ankles can be common, and also other joints too, like elbows. In the feet, it isn't always the big toe joint, although most commonly. And this is actually just a chap I saw last week who very kindly allowed me to take a photograph of his foot, because I was telling him about this lecture, just to show that this is the second toe, and you can see that those gouty tophi are there within that joint space. Otherwise, his arthritis is quite quiet at the moment, but that toe rubs in his shoe. So we've got a little silicone sleeve that goes over the top of that to stop it rubbing. So some things are really quite simple and yet make a difference. And if it doesn't hurt his foot, he can keep active, which is crucial. Still on the big toe joint, and talking a little bit more about the bunion, because it's very common. 1 in 3 people over the age of 65. And as we said earlier, it gives a funny shaped foot for getting into a shoe, makes footwear uncomfortable, and increases the risk of falls, because this part of the foot doesn't support body weight as well, and means that someone has diminished balance. Sometimes they require surgery to realign the joint, but that's usually regarded as indicated at the failure of conservative care, and non-surgical management is always preferred. And that can involve a number of things independently or in combination. Changing footwear is nearly always part of it. Foot exercises can help to strengthen the muscles to stop the big toe drifting. Foot orthotics can help to stabilize this big toe joint. And as we can see here, toe spaces and splints to try and keep the big toe straight over that big toe joint. And usually it's a combination of the lot. We do know for bunions that intervening with footwear and foot orthoses can reduce the high pressure at this big toe joint, and it does that by increasing the pressure through the arch. So relatively, by increasing the pressure through the middle of the foot, we take the pressure away from the heel and the big toe joint, and that can be designed to be quite specific and can give a lot of relief, and also in some instances stop that toe drifting, usually in combination with applicable footwear and exercises. And as with every other part of the body, foot strengthening is incredibly important, and probably in the last 10 years or so, foot strengthening has become more and more part of the podiatrist's approach to foot pain and most foot problems, because the foot, as I showed you before, is a really complex structure. Lots of bones, many joints, and a myriad of muscles. And if those feet get weak, then all of those joints can be affected. turn that round the other way, and if we can keep the feet strong, just like if we keep the rest of the body strong, then we have a lot less problems, a lot less foot pain, keep people mobile, keep them healthier. Some exercises, as you can see here, are actually done on the feet and trying to isolate the big toes to strengthen these important joints. Some are done non-weight bearing, stretching all of the joints of the toes to the feet as well as the ankles. Some are done manually, stretching these joints where the toes connect to the foot and also the ankle. And then some are done tiptoe standing exercises, which can also be really good for balance as long as they're done safely. This is actually a really handy tip for people. Well, it's a great way to strengthen feet using resistance bands. And it's a video, it's only about 1.5 minutes, but it shows you how you can isolate, as you can see here, particular joints of the feet. So we'll play that, and some of these exercises could be applicable for you.
One of the ways that we like to use our resistance band to build strength in our feet is to target the flexor muscles of the toes. So what I've done here is I've placed the band underneath my foot and then I've looped it around just my big toe. So I can pull with as much tension, as much or as little tension as I feel comfortable. And then I'm going to keep my outer toes on the ground if I can, and just lift up that big toe and then press it all the way back down to the ground. Hold that for a second or two, come back up, and then keep repeating. And we like to start this with about 20 reps. We can absolutely go up or down, but 20 is kind of a good range. And then we're going to repeat the same thing with the outer toes. So I'm going to keep that band flat on the ground. I'm going to move my foot over, and now I'm going to loop it around my outer toes. And then same thing, I'm going to try to keep that big toe on the ground, reach my toes out long, and then press them down. And one of the keys here is that we don't want the toes to start hammering. So really try to reach those toes long. If you need to get a glimpse at them, you can also, when you're lifting the band, lift it so that you can still see your toes and watch whether they're curling or whether they're pressing flat. Now, when I say curling, what I don't want is this motion, but it's okay if when you're pressing down, it kind of lifts the tips of your toes, if you will, and so it kind of curls up. That's okay. But what I don't want is I don't want a gripping or a curling or clawing motion there. And again, I'm going to start with about 20 reps on each side.
Okay, so I think that's actually a really helpful little video. And you can see how just using that resistance band, you can really isolate the big toe and the small toes very clearly, and make sure that those flexor and extensor tendons, bottom and top respectively, work together by not buckling the toes. I think she made some really good points. The one thing I would say, though, is that I find generally when people start, particularly if their feet are a bit weaker, I find 20 reps a bit much. I'd probably do 10 twice a day and build up slowly. But really good tips for specific joint strength. And those bands come in different resistances too. All right, so now just very quickly finishing off, because I don't want to give you the impression that it's only the big toe that's affected in the foot. As I've said earlier, the midfoot can be affected, and by the midfoot we mean really where the metatarsals join the middle part of the foot. And again, a very complicated area in terms of joint configuration. And this is an area that is commonly affected, causes stiffness of the foot and considerable pain. Some research by a colleague of mine a few years ago showed that foot and ankle symptoms significantly increased the odds of developing knee symptoms for people with arthritis. So, and this shouldn't be surprising, one, because the disease process is likely to be more widespread, but also potentially, because if the foot isn't working properly, then as I showed you earlier, neither is the ankle nor the knee. And there's an interplay both ways. We can see here like a normal ankle, again, a nice clean joint, widely spaced, versus an arthritic ankle, where again, that joint space is obliterated, sclerose, that's a word for that whiteness, which means the articular cartilage is degenerated and joint space is lost. And then here in the knee, again, we see a normal knee joint. You'll be getting good at looking at joint lines now, versus when the joint space is lost with degenerative osteoarthritis in this case, and associated pain. So that's very quickly midfoot, ankles, knees. But I do just want you to know that when the feet hurt, there is more likely to be problems, particularly in the knees and also the ankles. So footwear, we've spoken about exercise. I've mentioned body weight and how important it is to keep that within regular limits, but it obviously is not something you can do quickly, whereas footwear is something that can be changed quickly and can make a big difference. And we know that footwear interventions, and this is from a study a New Zealand colleague of mine looked at, found that footwear interventions were associated with reduced foot pain and less disability in people with rheumatoid arthritis, less foot pain, better function, less disability in people with gout, less foot pain, better function in people with big toe osteoarthritis. So in other words, footwear really, if it's well selected, can help all forms of foot pain across the arthritis range. Footwear has been shown to reduce the pressure, so the pressure under the big toe joint in rheumatoid arthritis, gout and osteoarthritis, and improves walking speed in people with rheumatoid arthritis and gout, but not so much in osteoarthritis where the joint is stiff. And I was thinking about this, and I thought of what one of the approaches that we tend to look at clinically is that for people with rheumatoid arthritis, we often look at extra depth footwear so that there's room for swollen joints as well as cushioning underneath. For people with gout, we tend to look at support and cushioning. That joint's often inflamed. And then for the big toe joint, we tend to look at rocker soles, and I'll show you those in a moment. But some of the principles of fitting shoes, we need to make sure that the shoe actually is, as well as we can, the same shape to the foot. And we know that feet come in different shapes. Depending on your ethnicity, depending on your family pattern, we know that people have different shaped feet. So ideally, they would have different shaped shoes so that they match. Now, that's all very well as a theory, but when you get feet that are this shape, that becomes difficult. And that's when we need shoes like this, for example, that have a soft wetsuit-like neoprene top to it that is soft and can shape to a misshapen foot with good cushioning underneath. And usually in a foot like this, supplemented with some form of orthotic. So in principle, we need to try and match foot types to footwear structures. And very basically, I'm going to introduce you to the concept that there are three sort of different types of feet: the low arch foot, which makes the big footprint, the medium or regular foot and the regular footprint, and the higher arch foot, the less common, which has a footprint with only a little bit of weight bearing on the side. So we see mainly the regular and the flatter type feet in the community, but each of these footwear types needs to be matched with appropriate footwear. And generally, the flatter the foot, if you like, heading over this way, the more the footwear should be supportive. The more regular the foot is generally this neutral shoe that just gives adequate support for a regular foot structure and walking. And then up here, this high arch foot, the less common one, it needs more cushioning. That's really important, and it doesn't need support in the arch because it's already got a high arch. So that's in a nutshell. And if you go into good sporting shops, they tend to go through this process with you and generally do a fairly good job of it. So it's all about matching feet and shoes. So the lower arch foot, generally a bit more support in the arch of the shoe, the regular foot, the regular shoe, and the high arch foot, the more cushioned shoe. That's what we tend to look at. If we look more specifically at footwear types for feet that are a little bit trickier to fit, we often look at extra depth shoes that we can get not only the foot into it, and a foot that may have toes that take up more room, being buckled or out to the side. They're often extra width as well, but also room to get an orthotic in there for extra cushioning and to offload some of the high pressure areas. Orthotics come in all different shapes and sizes. They can be pre-made and sometimes adapted. They can be customized for each individual foot and pair of feet. They can be just cushioned only to supplement the shoe, and some of those can be bought from regular shoe shops or even pharmacies, or they can be rigid foot plates, really thin carbon foot plates that go into the shoe to stop the big toe area bending for that painful arthritic joint. That can really help some people. And others can be padded. We need to look at socks as well, because they can also help to reduce friction and add some cushioning and give a little bit more when the foot is swollen. There are a couple of things I just want to point out in a shoe. This notion of pitch, which is how high the heel is elevated versus the front of the foot. And your average shoe is higher at the back versus the front. And what we call the pitch is the height under the heel less the height under the front part of the foot. And generally that's sort of around 10 to 16 millimeters in an average shoe. In someone whose big toe joint is very stiff, lowering the pitch can take some of that bending force off the big toe joint and give considerable relief. So pitch can really be something to be modified to make that joint work better. I just want to also mention the notion of rocker-soled shoes for people whose ankle doesn't work properly, or particularly their big toe joints or their midfoot joints, if they're really painful. This shoe can rock, and you can see that the heel is cut away, and so that the rocking occurs gently as the foot hits the ground. It rolls through the midfoot and then rolls off. And that can really be very helpful for some people, but other people are quite unstable on them if they don't have adequate balance. So it's like everything else: horses for courses, shoes for feet, and shoes for particular people. But these are some things that can be very helpful. But coming back to it again, it's all about getting people moving on with least pain, best function, particularly from the foot point of view, where it is often affected in that big toe joint, but it can be the midfoot, can be the ankle, can be the Achilles tendon. And if someone isn't walking correctly, then that can affect their knee, their hip, their back as well. And that's really what we're about, is keeping people active. So I think we've probably largely answered this now, and we're getting towards time. The one thing I was just going to focus on here is a really helpful website for you from the Australian Podiatry Association, and it's called Find a Podiatrist. And so if I can, with a bit of luck, open this link for you, we can see if we can find a podiatrist. Here we go. So this is the website you'd be looking at, and this is freely available. You just click up here at Find a Podiatrist. And then if you put your location, and let's say Adelaide, okay, say Adelaide, and say within a radius of 10 kilometres, say the last name of the podiatrist, look at this, pick Evans and search. And, oh, didn't find me. It should. It found me before. Let's have a look at this. I'll try it one more time. Oh, it's the range, I think. Adelaide. That's it. Let's see if it can find me this time. No, it's not. Well, anyway, it normally works. I'm sorry about that. But it's a very helpful tool because, as I say, you can search according to location and find a podiatrist. It also has this very important function here of member interest areas. So it may well be various diseases. It might be diabetes, general treatment, high-risk foot, or even home visits, or whether an aged care facility visit is possible. So that site is worth knowing, and it will probably work better on your computer than on mine. And other than that, I think it's probably now pretty much going to be time for Q&A. If there are any questions.
So someone's asking that when they try and stretch or flex their feet at the end of the day, like opening their toes and things like that, they experience a lot of cramps in their feet. Can you give any advice about that?
Yeah, well, it's interesting, you know, there's a lot we know about cramps and a lot we don't know about cramps. Some people cramp because those joints are actually quite weak at the end of the day, your feet have probably fatigued a little bit more. Some people cramp because they're dehydrated too. So it might be a factor local to the foot, as in weakness, in which case those particular exercises with the resistance bands can be a great way to build toe strength specifically. But otherwise, do just think of some other obvious things like your level of hydration at the end of the day, particularly if, like me, you know, it can be coffee 3 to water 1 some of the time. That's not a good ratio.
Perfect. Really well answered, Angela. So someone's asking if you can comment on the outcomes of surgical fusion in foot joints, midfoot and ankle specifically. Is that kind of in your scope, I'd say?
I see it. It's not something that I do, and it's generally something that is done when everything else has been exhausted conservatively, and the joints are so painful that the only way of getting that person some pain relief and trying to restore mobility is to actually fuse one joint to another. The ankle fusion, what's often called a triple arthritis, really means that the foot and ankle are like one unit. So for walking on flat surfaces, that can be quite effective with adequate footwear, but hills and things like that become quite difficult. So if it's an older person and their foot pain is really miserable, their quality of life is terrible, and they're not moving because of their foot pain, then a triple arthrodesis or a fusion can actually restore more total movement by getting rid of their pain. But if it's something that generally is good to reserve for as long as possible, because it does mean the foot is a lot less mobile. So, bushwalking and things like that, forget it in most cases. Similarly with the midfoot, and even down to the big toe joint too. Once the joints are fused and stiff, it means that other surrounding joints have to compensate. So we don't want to do that too soon, or if we haven't exhausted the more functional things like orthotics, footwear, the easy things relatively, and particularly foot strength. That is really important.
So it sounds like many other joint replacements, that it's trying a lot of other things first, and then if it's at the case at the end of the day, having those conversations with lots of professionals to make sure it's the best option for you.
Very much so, very much so. And ankle replacements aren't, to my knowledge, as straightforward as things like knees and particularly hips. They are becoming better. There's some good progress happening, particularly in the US, but it's a very difficult joint to actually replace because it's those three joints, the two joints of the lower leg, plus the talus, that bone in the middle of the ankle, and then it joins onto that complicated foot.
Really well answered there, Angela. Someone's asking if there's a good site to get foot exercises, or is that something they should have more of a conversation with a podiatrist or a physiotherapist with?
Yeah, absolutely the latter, because I find that most of the sites, and there are so many, I guess is the thing. They can be good, but it's really helpful, particularly if you have foot pain or some conditions associated to feet and arthritis. It's really good to know what's going to be specific for you, because some exercises, as well as being helpful, can actually make things more painful where they weren't before. So a little bit of guidance initially, and a lot of clinicians will actually then share some YouTube sites, or may actually set you up with a video of you doing exercises so that you've got that on your phone, and that's as specific as you can get.
Really well answered, and it probably flows into this next question pretty well. Is someone's asking where to buy rocker sole shoes in Adelaide? Would that be as well something that they should have recommended by a professional too?
Yeah, so rocker sole shoes, yeah, yes, with caution, rocker soled shoes. The rocker needs to be in the right place for the particular area of the foot. Sometimes that needs to be done specifically with the help of a bootmaker, and it can be different left and right. They can be absolutely wonderful for people. It can absolutely restore their function and mean that they can walk pain-free, but we also have to make sure that it is applicable for someone, because not everyone's balance is great, and balance is very, it's different when you're wearing rocker-soled shoes, and we don't want people to go over, backwards and whack their heads. So yes, again, that needs to be specifically applied.
So it'd be one of those ones of, getting a referral to see a podiatrist and then going through that process through that professional.
Yeah, absolutely. And also, again, a graded process of familiarization with them too.
Wonderful. Someone's asking that their big toe joint hurts a lot if they touch it, but it doesn't hurt otherwise. If they're, walking, it doesn't hurt, like things like that. And they have been diagnosed with rheumatoid arthritis. They're asking, because it hurts when they touch it, is it generally a good idea to have their foot checked out by a podiatrist, even just as a preventative measure?
Yeah, it can be. I mean, there's a couple of ways of approaching that. One is, if it's really sore when it's touched, it generally means that that joint's quite inflamed. So we just need to make sure that your medications are doing what they should. even wider than that, and this is clearly not my field, but even some people with arthritis can get significant help with dietary changes too. The other thing is that footwear definitely can make a difference. Orthotics can make a difference. The extra depth footwear can be very good for someone whose joint is inflamed a lot of the time, having ruled out these other factors. And even sometimes, for some people, some intermittent use of a cool pack or an ice pack can really just give some local relief without complicating the situation with further medications. But, you know, anything involving medications and that wider picture of diabetes arthritis management, you want to check back through with your GP to make sure that that's good for every other part of you and any other medications you may be taking.
Really, really well answered there, Angela. And someone's asking for a bit of personal advice that might be the same kind of the story with it. Someone's saying that they had a fall about 20 years ago, and now one ankle clicks and the other hurts when it's bent upwards. And that's the question around that. Do you think it'd be worthwhile them trying to see a podiatrist about this, or is this something they should have a conversation with their GP around?
Yeah, well, I mean, either or, but you know, podiatrists are about feet, so I would probably start there with that one. Anything that is likely to reduce your mobility now or into the future, you really do need to take seriously. You know, we can't rub things out and pretend they haven't happened, but there's often something that can be done that may be as simple as altering the height of the heel of the shoe up or down 5 millimeters can make a difference to the way the ankle works. So it's really worth investigating that, because we absolutely know that if you want to live well and have a happy, healthy life, and as you get older, you need to keep moving, and a good pair of feet are very much part of that.
Perfect. That's a fantastic way to end the night. It's an uplifting message, and one of the ones that, you know, we always say it's never too late and it's never too early to kind of start prioritizing your life and doing the best and putting things in place to live well with any type of arthritis. So I'd like to thank you a lot for your time, Angela, and staying a little bit past kind of the hour mark. We really greatly appreciate you and your expertise, and we greatly appreciate everyone for joining us tonight. So thank you very much, and I hope you all enjoy the rest of your night.
Thanks very much, Ben, and good night, everyone.